Redwine. I'm Laura Redwine, and I'm the clinical research director of the University of Miami Osher Center for Integrative Health. It's my pleasure to introduce to you Michael Spertus, MD. He's the Chief Clinician Wellbeing Officer and in Whole Health and Pain Medicine at the Miami VA Healthcare System. He is a professor in the Department of Family Medicine and Community Health at the Miller School of Medicine. And Dr. Spertus is board certified in family medicine, integrative medicine, and lifestyle medicine. He's also a certified professional coach. Dr. Spertus graduated with his bachelor's degree from Brown University in biology, brain, and behavior with honors, received his medical degree from the University of Miami Miller School of Medicine. He was the chief resident at Columbia University, where he did his residency in family medicine. He did a fellowship in integrative medicine at Mount Sinai School of Medicine, a fellowship in health professional education at Harvard Medical School, and did a fellowship in primary care psychiatry at University of California, Irvine. He has training and expertise in biofeedback, pain reprocessing therapy, medical acupuncture, cognitive behavioral therapy, and has training from the Institute for Functional Medicine. He has certificates in mindfulness and psychotherapy from Harvard Medical School, a certificate from the American Society of Clinical Hypnosis with a focus on medical hypnosis and chronic pain, certificate in plant-based nutrition from Cornell University, certificate as a professional coach, and he also is a registered yoga teacher, with 200 hours from Yoga Alliance. And so without further ado, I would love to introduce you to Dr. Michael Spertus.
All right. Well, great to be with you all. Thank you for that very comprehensive introduction. So today I'm going to be talking to you all about the whole health approach to chronic pain. And there's lots of different terms that get thrown around these days. And so we'll talk about this term whole health in a little bit more detail as we go along here. And a really important topic, of course, chronic pain. All right. And so first, what I'm showing here is a circle of health that we have that we use at the VA for this whole health approach. And you can see we say it starts with me. It starts with the person at the center. And around that is mindful awareness. So what I always like to do to start these presentations is to actually just settle in a little bit with a mindful awareness experience. Just a couple of minutes here. I know a lot of you are coming from one thing and going to this, and then you might have something right after this. So let's just settle in and transition. So I invite you to close your eyes for a moment, if that's available to you. I'm just noticing your posture. And if you find that the shoulders are slouching, or if you feel uncomfortable in any way, just making any adjustments you need and noticing those postures, those muscles. Settling into this moment, into this space. Bringing awareness to breath. Noticing if it's rapid or regular. Just beginning to take some slow, deep breaths, bringing some pause and slowness to the breath. Inhaling through the nose and exhaling through the nose. Noticing the expansion with each inhale and the release with each exhale. Slowing down transitioning. Noticing the change, even just for a moment of slow breathing and mindfulness, the quality of mind, the muscles, the body, to any sense of tension, or perhaps now some more ease. When you're ready, letting go of this brief mindfulness exercise, opening the eyes if they have been closed, and now beginning today's presentation. So objectives for today: to describe the whole health approach and its relationship to chronic pain. By the end, we'll also be outlining the evidence on select non-pharmacological, we're going to call complementary and integrative health, or CIH, pain interventions, and develop a plan to integrate whole health and CIH modalities into pain management. So first, I'm just going to begin with what does the state of chronic pain look like, with some background and demographics here. So here showing a figure of the high impact chronic pain in the United States and chronic pain overall. And we can see that it's pretty consistent over the last few years, just hovering above that 20%. And that high impact chronic pain, which is pain that results in substantial restriction to our daily activities, is just below that 10% range. Now, if we look at this more, and this is from the National Center for Health Statistics, um, the demographics and percentage of this does vary by certain things, especially age group and actually by veteran status as well. And so I bring this up, of course, because I work within the VA system, but it's important too when we're thinking about our population overall. So what we see is that generally chronic pain tends to increase with age, and also veterans across the board tend to have more prevalence of chronic pain. So overall, it's about 20% or so, with non-veterans slightly higher. And with veterans, it's actually 31.5% experiencing chronic pain in the last 3 months. As we can see, with veterans, it actually is younger and it catches up by age 65, which is what we expect. Chronic pain does increase with age for most age groups, for most of the population, I should say. And then other impacts here. So, of course, we've all heard of the opioid epidemic. And I bring this up because it's important when we're thinking about pain and our interventions. And unfortunately, opioids are not a great intervention as a first line. And a large part of this has to do with the risk of addictions and overuse. And so, as you can see, actually, on the right-hand side first, um, going back even to 1999, the overdoses that were there were initially driven by prescription opioids. And then more recently, as you can see, overdose deaths have been increasing. And that more recent increase has been driven largely actually by the synthetics, especially fentanyl. I bring up low back pain because it is one of the most common forms of chronic pain. And based on a recent systematic review, the lifetime prevalence of low back pain is approximately 40%. Globally, low back pain is the most prevalent and disabling condition and is the highest generator of healthcare expenditure and disability. So this is important, right? It's common and it's resulting in pretty substantial disability and healthcare expenditure. And so I bring this up. I think it'll be difficult to use the chat feature for this part. So I'm just going to say what these are here for chronic low back pain treatments. There's lots of things that are within our toolbox that are commonly used. However, unfortunately, a lot of the things that we do use actually have poor evidence of long-term benefit on pain or disability, including muscle relaxants, anticonvulsants, including gabapentin, which often gets prescribed off-label. Most antidepressants, with the exception of duloxetine, corticosteroids, TENS units, epidural steroid injections, radiofrequency ablation, spinal cord stimulators, spinal fusion, All of these may have their individual place for an individual patient. However, overall, and this is from a recent review from American Family Physician, these have poor evidence of long-term benefit on pain and disability. But we are still using them. So our treatments that we're using are maybe not the best. And then in addition to this, and in the same vein, chronic pain is complex. And it's not just, I always say it's not just one thing. It's not just the anatomical. It is multiple different factors that contribute to pain. And so here showing a couple of definitions from the International Association for the Study of Pain. They recently updated their definition actually for the first time in quite a while. And so the old definition is that it was an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. The new definition also adds this piece of or resembling that associated with, and that broadens our definition. And so, first of all, even the old definition is including the potential tissue damage, right? So it's not always that it is there, but also this idea of resembling. This includes things like phantom limb pain, for example, or other pain symptoms that we know that now exist. Pain that is experienced is real. So it's ultimately the pain experience that is what is there. And that is a subjective experience. And it is all processed in the brain. And this has to do with many different ways that this happens, but it has to do with the context, the beliefs, expectation, placebo, the cognitive set that we have. Is there hypervigilance or hyperfocus on the pain and pain-related mood and behaviors? Mood often goes hand in hand along with this. And so it's one of those things where is it the chicken or the egg? Depression over 80% overlap with chronic pain, for example. And then, of course, the biochemical piece too. I often say many of the same medications that are used for pain are used for mood disorders as well. And this is because it's many of the same neurotransmitters that are involved. And all of this can result in modulation. The brain itself from the central nervous system is affecting this modulation both up and down. And so pain can be amplified in certain syndromes as well. So I introduce this whole health approach as a path forward as a result of this complexity that we have with chronic pain. And so a couple of pieces. I mentioned that this idea that it starts with the person in the center. In whole health, and this is from our materials within our VA national system, it starts with the person, and we move away from asking the question, what's the matter with you, to instead asking what matters most to you. And this is a big change, right? Because oftentimes in our allopathic approach, in our Western medicine traditions, we ask, what's your chief complaint, right? And so we're using a different approach even just to start the conversation here. What is it that matters most? And then here we're taking a look at these different factors, mindful awareness, and then moving back from there. What are the different factors that are contributing to health and well-being overall? So we use this approach in health in general, and in this case, as it relates to pain. So starting at the top there, moving the body. We know that motion is lotion, I like to say. And movement in general is one of the best medicines. Exercise is one of the best medicines. Helps you to produce your own pain-fighting chemicals, the endorphins, the dynorphins, helps with stability, helps with the mobility, and helps with flexibility as well. But finding the right kinds of movements, and that's not just exercise, right? I always ask, how are you moving throughout the day? Are you using any assistive devices to get around? Are you able to walk? All of those things come into play too. So it's not always just, are you going to the gym? Because that's often what I find is asked about more formal types of exercises. And finding the right kinds of movements as they relate to pain, working with the pain. And sometimes this is where the role of pacing comes in, starting low, going slow, sometimes building back up, because over time with chronic pain, activities are often avoided. Surroundings in the next circle, physical and emotional surroundings are important. Are people able to get outside into nature, or if they're inside a lot, are there windows around? In that diagonal, who are the people that they're surrounding themselves with? Family, friends, coworkers, relationships with others. who is providing support and who are they supporting? Is the kitchen clean and organized to make healthy food in as it relates to that food and drink there? Um, Personal development, we often think of this as the balance of the work and life together, but a lot of people with pain have disability and are not working. And so I often like to think of this as on a regular day, are you having more activities that are actually nourishing you or activities that are depleting you? And how do you build then that better balance? Um, Food and drink, here I like to think of this as what is going into the body overall. So just like pain medications, many of them are having anti-inflammatory effects on the body. Food is also medicine. It is having biochemical effects in the body, can be inflammatory or anti-inflammatory. And thinking about other things that might go into the body, tobacco smoke, alcohol, right? All of those are having their impacts on the body too. Recharging. Thinking of the internal battery. Is it on high? Is it on medium? Or maybe is it even completely depleted on empty? And how do you recharge? This is where the role of stress and the stress response comes in, and also the role of sleep. And so asking about what are things that the individual is doing to recharge, to wind down for relaxation, or just for stress reduction, or even just hobbies, things that you might enjoy doing. Um, Also with sleep, very important connection here as it relates to pain. Many, in my case, I often say veterans, but patients in general have difficulty with sleep and when they have chronic pain as well. And often it's the pain that might be waking them up, right? Well, so often the answer is, well, we need to improve the pain before we can improve the sleep. What we now know, though, is that because sleep is so important, it's one of the essential lifestyle factors. It affects the immune system, the nervous system. The reverse is also true. So poor sleep actually worsens pain, as it turns out, as part of the neuro feedback loops. And so what's been shown in certain meta-analyses is that by approaching and treating sleep, whether that's from apnea or from insomnia, the difficulty falling asleep, staying asleep, is that by treating the sleep and focusing on the sleep, not only does the sleep improve as expected, but pain levels actually improve. And in some studies, actually up to 70%, which is better than most pain medications, actually. So sleep can often be a doorway in. I talked about family, friends, and coworkers, spirit and soul. What allows for that growth and connection, perhaps a spiritual practice to allow for more meaning and purpose. And then finally, power of the mind, a very important one as it relates to many things, and especially as it relates to pain. And this has to do with the neuroscience of pain, because as I mentioned, all pain is ultimately processed in the brain, and levels of pain can actually be modulated through the power of mind up and down. And I'll go into that in some more detail coming up. All right. And then I show this as well because from this whole health approach, for it's not just the individual things. It's also the community in which we live and the social determinants of health. Unfortunately, the VA has actually taken this out for reasons outside of our control, but these are the things that we know through research that contribute to health and also are associated with poorer outcomes and prognosis when social determinants of health are not in good condition. All right, so a poll question here, and we'll take a look at the chat for this. So you may or may not be familiar with the whole health approach. So we're going to talk about a concept called the MAP. So what do you think the MAP stands for as it relates to whole health, whole person health? Money and power, A, B, mission, aspiration, and purpose, or C, meaning, affiliation, and progress. So if you can use the chat feature, we'll just see if we can get some answers there. D, C, C, B, C. So lots of C's. Okay. And another B. So it does actually, it is B, mission, aspiration, and purpose. And I actually love this concept from Whole Health. Refer to this map. So I say that just like a physical map guides you where to go, your personal map, mission, aspiration, and purpose, or sometimes I actually just abbreviate it to meaning and purpose. It's easier to remember. It is not a question that's often asked, I find, in our standard medical practices, but it really helps to build rapport, and it helps in the case of pain to move beyond the pain. What would you do if you were not to have more pain? What might you do more of? What is it that you can um, what is it that's truly important to you, or what do you wake up for in the morning? What do you need, or whom might you need to help you to get there? And so I do this reflection exercise in my whole health clinic, actually, with patients who have chronic pain to actually determine what that map is for them. And we actually, in whole health with the VA, we actually track this as a measure, believe it or not, now. And it is a really helpful doorway into understanding our patients a little bit more. And it's helpful for the veteran to be in line with that because we have all these different options we can throw at them, right? Whatever it might be. And it can be even lots of appointments. So how can we help prioritize things? Many people, for example, mention that their family or religion is important to them. Well, are you doing things that are in alignment with that? Or maybe you have, say, too many appointments even that are inhibiting you from doing those things. So when we talk about some of the different options, how can you map to your map, we like to say, or how can you be in alignment with what really matters to you? And we have ways of filling this out, actually. It's called the PHI, the Patient Health Inventory or Personal Health Inventory. And actually, we have our employees even do this as well, all the new employees. And it could be a good reflection for getting a sense of that map and to where you stand on some of those other areas of that circle of health that I showed. And the other reason this is important for pain and moving beyond it is because pain itself, as I showed before, it's so complex. It can be so all-encompassing, right? We begin to get tunnel vision with chronic pain. How do you move beyond this? And this is one way to begin to think outside of that. Okay. So next here I show how whole health is integrated. And this is important because it is not just for tertiary pain care centers or referral centers, right? The idea with whole health is that it's actually integrated within all levels of the recommended stepped care plan for pain management, beginning at the foundation, self-care, then moving into primary care, specialty care, and tertiary pain. Now, my clinic is in the tertiary center. However, we recommend whole health. Whole health, we say, is everyone's responsibility and is at all of these different levels. And so I often begin the conversation with what the self-care plan does look like. So I just love this little quote here in this cartoon. It shows a doctor giving a patient a pill. So to prevent a heart attack, take one aspirin every day. Okay, we've heard that before, although maybe not as recommended as it used to be. Take it out for a jog, then take it to the gym, then take it for a bike ride. The idea that it's not really the aspirin or the medication that's having the greatest impact. And studies support this, right? Actually, over 80%, maybe closer to 90% of health is not going to the doctor, going to the hospital, even taking the medications. It's all those things that people are doing on their own on a regular basis or in their communities, those things that were within the circle of health, the diet, the nutrition, the exercise and movement, the stress and stress reduction, the sleep, the relationships with others. All of those things have much greater impact and social determinants of health as well. And so we have actually through the VA, whole health coaching, and I think I have a slide on that later, as a great program to help optimize this. We also have many apps that we recommend within the VA, and there are others outside the VA that can be really great tools as well to be used. And all of these apps that are shown through that are VA related apps, these are available for everyone through any of the app stores as well. And they are free for regular use. So you're welcome to look into these as well. All right. And then I like to show now a focus because sometimes we hear words like integrative medicine, whole health, and that must mean that we're doing only, alternative things. The idea with this is that complementary and integrative health is integrated into the regular practices. So that's why we have moved away from using the terminology, CAM or a complementary and alternative medicine to integrative health. And now we seem to be moving more actually toward this idea of whole health or whole person health. And the idea here is that this is part of standard care now. And so what I'm showing here is actually a figure showing that this is part of the guidelines now to actually recommend complementary and integrative health as part of pain. This is from Pain Management Best Practices Task Force from 2019, and then they updated this actually in 2023, same similar recommendations. This is one of their 5 areas that they recommend. All right. And we can see that the rest of them too, things that we often might otherwise recommend. So medications, of course, restorative therapies, interventional procedures, and behavioral health approaches are all part of this practice. Multimodal pain treatment is the gold standard for pain. And the problem, unfortunately, in many cases, is access as well as knowledge about these things. Just to discuss, I know I'm talking to an audience about integrative medicine. However, I do just like to highlight some of the definitions for how this can relate to pain as well. And so this definition of integrative medicine is from the Academic Consortium for Integrative Medicine and Health. And I just like to highlight a few words here. So integrative medicine and health reaffirms the importance of the relationship between the practitioner and the patient, focuses on the whole person, which is in line with this idea of whole health, is informed by evidence, and makes use of all appropriate therapeutic and lifestyle approaches, healthcare, and disciplines to achieve optimal health and well-being. So this is exactly what we're doing in whole health. And that's why sometimes it's just these different terms, but sometimes these different terms like whole health are more accessible or people get it more. So we change these over time. So right now, integrative medicine and whole health are going together. So what are some of the things that can be used and some of the ways that we can categorize some of these complementary or CIH modalities? So this is one way of putting them in. This is from a review in Nature. So we think about maybe the manipulation-based or hands-on based therapy. So this can include our massage therapy, chiropractic, osteopathy. Some people would include acupuncture in this too, but some of these overlap into other categories, right? Because that can go into perhaps the alternative medical systems, because traditional Chinese medicine based, right? Or maybe even energy, because you're doing the flow of qi historically. Yoga, mind-body interventions, mental health interventions often are part of this mind-body, right? When we think about even CBT for chronic pain, this would be there. We have the movement-based as well, which are part of these systems as well. Usually that would be included with the biologically based approaches, the more primarily musculoskeletal. Also, functional medicine, naturopathy, nutrition would be on these biologically based approaches generally as well, although some of them on the energy side. So these can be overlapping, but the idea is just to show how we can begin to categorize some of the different modalities that are available. And this shown here, this is not exhaustive. All right. So now just showing some of the evidence here, and this is quite a busy chart, just showing lots of different things that have been shown to be helpful for pain. This is from 2018. And we can see on the y-axis the effect size, and then we're looking at the bottom, pharmacological versus non-pharmacological. And so we can see here actually that many of our non-pharmacological or CIH interventions have actually pretty decent effect sizes, as we can see here. And so just to highlight a few, multidisciplinary rehab, so that highlights that multimodal approach there. And relaxation hypnosis have some of the highest effect sizes, actually, although they're not always the most used. CBT, which is pretty much the #1 first-line treatment in all chronic pain guidelines almost, has a moderate effect size there as well. All right, and so here, just again, synthesizing some of the strength of the evidence for complementary and integrative health therapies for pain, looking particularly at acupuncture, massage, tai chi, and mindfulness for different effects here, just to show the range for which these things can be used for. On the left, going from no evidence of effect to evidence of a positive effect. And as you can see, mostly we're in this kind of middle zone for where the evidence is now. A lot more research does still need to be done, but we have made significant headway. And actually, this was from 2019. I haven't seen the updated version of this, but the research has continued to balloon since then, particularly for, I would say actually for all of these different areas. All right, and this is just to show at the VA with what we recommend a lot of these different therapies for. So looking at, say, fibromyalgia, we're talking about pain here, acupuncture, CBT, exercise, hydrotherapy, mindfulness, Tai Chi, myofascial release. Insomnia, since we talked about how that can go along with this. Cognitive behavioral therapy for insomnia is the gold standard therapy across all guidelines, including the American Academy of Sleep Medicine and mindfulness-based stress reduction. And then low back pain, and I'll stop after that one. Acupuncture, exercise, CBT, massage, mindfulness-based stress reduction, spinal manipulation, Tai Chi, and yoga. So lots of different things for lots of different conditions, right? And then showing some of the more used guidelines, I just like to show this as well. This is from Annals of Internal Medicine and the American College of Physicians guideline for low back pain. They updated their guidelines in 2017 and continue to recommend non-pharmacological interventions, including CIH modalities, as first line, based on the evidence, including multidisciplinary rehab, exercise, acupuncture, mindfulness-based stress reduction, Tai Chi, yoga, motor control exercise, progressive relaxation, biofeedback, low-level laser therapy, operant therapy, cognitive behavioral therapy, and spinal manipulation. And so whole health coaching is another tool that we have that focuses on that self-care piece, right? So within the VA, we have specific coaches that are actually going through the circle of health, helping our veterans to identify what are their strengths and values, what is their meaning and purpose, and what are their goals, the goal setting. So it's not prescribing, not telling what to do, but using the coach approach. And so having health coaches in general, especially ones who are trained in pain and pain-related behaviors, can be extremely valuable as an option to add and to actually help determine, because we're so used in allopathic medicine to saying, oh, do this, do this, do this. And unfortunately, that's not always the best thing. We want to use more of our motivational interviewing skills, and using more of this coach approach, shared decision-making can be really helpful. What is it that the patient wants, and what are their goals? Whole health outcomes. So showing what use has done as it relates to chronic pain from some of the evidence within the VA. Those who have used whole health services with opioid use has decreased. So 38% for those who have pain, compared with only an 11% decrease among those who did not have whole health use. Use of invasive procedures, the spinal procedures that we talked about at the beginning, have decreased. The rest is about some of this is about other things, including mental health diagnoses. But those who engage with whole health had 2.3 times the probability of engaging with an evidence-based psychotherapies. But sometimes whole health can be a doorway into other evidence-based practices as well. So it can be extremely valuable, and there is evidence behind use of these services. All right, so now I'd like to transition to talk a little bit more about some of the specific modalities, and particularly the mind-body approaches, as that's an area that I focus my efforts on a lot. And so I just like to show the definition of mindfulness here. This is from Jon Kabat-Zinn. It's the awareness that arises by paying attention on purpose in the present moment, non-judgmentally. And that's from mindfulness-based stress reduction. That's the creator of mindfulness-based stress reduction. And I use this definition because it's easy to remember, number one, and because we hear this word mindfulness or even meditation that comes up a lot now. It's important to have a definition for what is this exactly we're talking about this. And so this is the definition that I like to use. And then the power of mind in general. Okay, so this has to do with our mind-body connection, right? And we talked about this connection between mood disorders and chronic pain in general. Those who have chronic pain are much more likely, actually 4 times more likely to experience mental health conditions, and those who have mood disorders have an increased risk of developing chronic pain as well. These things are going together. And that's why this connection, it's not just one or the other. There's not some arbitrary disconnection, I like to say, between the brain and the rest of the body. There's constant communication that's occurring. So some of the most evidence-based practices here, and then we'll go into some others that are more innovative as well. CBT for chronic pain. There's actually lots of different types of CBT, as it turns out. So there's one that's developed specifically for chronic pain. This is really the gold standard, as I mentioned before. It's recommended as first-line treatment across guidelines. So the VA, DoD, NIH, CDC guidelines all recommend CBT for chronic pain as the most empirically supported behavioral intervention. We take into account the that pain does not live in a vacuum. There are thoughts that we have about pain. There are emotions, and then these feed into each other. And so how do we break the cycles of chronic pain? And so you can see this circle here, the chronic pain cycle that often occurs. So you have chronic pain, you begin to become deconditioned, avoid activity, then can develop negative emotions and thoughts, might have then avoidance and withdrawal, and then increased distress and disability. So the idea is to break these cycles, develop healthier patterns. And then what this has been shown to do is actually decrease the distress, the disability, and this has a way of actually decreasing the pain itself, as it turns out as well. Mindfulness-based intervention. So there was a great study done that was published in JAMA as a landmark study that was actually looking at mindfulness-based stress reduction versus cognitive therapy or usual care on back pain. And what was shown is that MBSR had basically no difference compared to CBT. Both resulted in greater improvement in back pain and functional limitations at 26 weeks. And mindfulness-based interventions, and now there have been many, many studies showing the benefits of mindfulness and meditation-based therapies on pain, including even interesting ones that separate out. Is it the mindfulness? Is it the breathing? Is it both? And it seems that they're both aspects of that have benefit. Breathing itself is actually an analgesic. I went to a really interesting talk about this recently. Pain reprocessing therapy. So this is the new kid on the block, things that have been talked about a lot in the pain psychology world. So we have dedicated pain psychologists who provide these psychology-based oriented approaches. I myself am trained in pain reprocessing therapy and provide this as well. And it incorporates a lot of different things, I would say. It helps to break the pain fear cycles, helps the brain to unlearn what we call neuroplastic pain, or sometimes it's called nociplastic pain as well. Particularly when I talked about that pain can be amplified through the fact that it's processed in the brain. So we want to reprocess, rewire the brain, the nervous system to be able to actually do this through different methods that have been shown. The data, and there's still more research in this needs to be done, but in this landmark trial that was published in JAMA Psychiatry in 2022 called the Boulder Back Pain Study, amazing results. So 66% pain-free or nearly pain-free. The effects and these results are really, they speak for themselves. And that's why there's so much interest in this particular treatment right now. What I will say is that it combines some other things that we already know about. It combines CBT principles. It combines pain's neuroscience education. It combines aspects of, I would say, hypnosis and mindfulness as part of it as well. Empowered relief, another interesting one that was developed by Dr. Beth Darnell at Stanford University. And some of these behavioral health slides were actually developed by her colleague as well, Dr. Kristen Slater. So the benefit of empowered relief, it's a kind of branded psychological pain intervention that has been shown to be done and be effective in one session. So it combines a few different things, mostly cognitive behavior therapy principles, including some other things such as mindfulness as well. And what's been shown is that, at least in one study, also published in JAMA Open, is that this single session 2-hour intervention was as effective or non-inferior to an 8-session CBT for chronic pain. So the idea, especially when we're thinking about access or cost, sometimes shorter is useful. And this is something that can be used with less time allocation overall. Hypnosis. So something that I am trained in and provide a lot of is really, I've included this in innovative therapies before because it's really been having a renaissance, so to speak, but hypnosis has been around for a long time, actually. But now the research is catching up more as it relates to chronic pain. There have now been several systematic reviews and randomized controlled trials that show moderate to large effect sizes, actually. So this is definitely a tool in our toolboxes for all types of chronic pain, actually. Psychedelic assisted psychotherapy. This is also another new kid on the block, although really undergoing a renaissance as well. I often get questions about this. I have a certificate training in psychedelic assisted therapy and research. So really the jury's out right now because we need more research. But with the most evidence is for ketamine assisted therapy, particularly ketamine infusions that have been done. And this has been done in interventional and mostly anesthesiology based pain clinics for a while, showing both short-term and long-term up to 1 year effects and benefits. And done in different ways. So it can be done also sublingually, and this has been shown to be beneficial, say, for chronic low back pain as well. For other types of psychedelics, there is a lot of interest in this, a lot of interesting theories and mechanisms of action, and certainly survey-based reports, but a lot of the evidence is still on the weaker side, small studies, observational, and survey-based. So we do need more evidence for things like psilocybin LSD, but due to different ideas of mechanism of action, neuroplasticity, anti-inflammatory effects, the fact that it's working, some of these are working through serotonin effects, so that association with mind body as well, and synaptic remodeling. And now virtual reality, another innovation that has come out recently that is so that people can actually do home care, right, for some of these mind-body interventions, pain psychology interventions to allow for unlearning of unhelpful cognitive and physiological patterns. There are many different kinds virtual reality that are now out there. We actually use these. We have contracts in the VA to be able to use these devices, actually send them home to our veterans, and with really interesting effects anecdotally, but we do have evidence to support these now. There are some that incorporate just the pain psychology pieces, some that actually incorporate movement and have, say, hand sensors as well to increase range of motion. So it's another exciting area. This is just to show one of the models that we use. That is a 56 session sequential structure that goes through, say, starting with the breath. You can actually, it uses some biofeedback as well. You can see the breath growing a tree, for example, in that first picture that you are shown. There's pain neuroscience education in there, attention and positive distraction, distracting the brain away from pain, because pain does not like creativity or positive emotion. And so by learning and being in a different state of positive distraction, even games, these have been shown to be helpful for pain. This is actually why we think music therapy is a helpful intervention for pain as well. Then it goes into relaxation, shaping the nervous system, noticing the body, bringing in more advanced mindfulness tools, and then how to move forward. And this is just showing some of the evidence for this, showing that there has been reduction that has been seen between VR versus a sham device. So it has been shown to be effective. And then finally, just to show some changes in systems. So how do you integrate all of this, right? I talked about the different steps that you have within the pain management overall, starting at that self-care, going all the way up to tertiary pain care services. So I want to talk about some of these more specialty-based models that we have for being able to integrate our whole health approaches now that we have at the VA. So within our clinic at the Miami VA, we have kind of a diffused model. So we have our pain clinic patients get referred, and then they can go to all these different things that are shown. They often might come to me as the whole health pain clinic that we have to then go through all of the different options that we might have available. They discuss these things in pain clinic as well, but all of this is actually part of pain clinic itself, including pain nutrition. We have a dedicated class, physical therapy, AMP, which is our active management of pain. Interesting model that that pairs our physical therapy team with our pain psychology team to actually build back in safe movement, among all these other things that are shown. So the idea, very comprehensive, lots of tools at our disposal. Then we have some other programs. So in Tampa, they actually have an inpatient program, which is really interesting. It's called CPRP, or Chronic Pain Rehabilitation Program, 19-day inpatient care that has actually been shown to help taper the opioids and some of the other difficult to come off of medications that are used by using a comprehensive multimodal approach to be able to do this, with pain psychology actually at the forefront, but also other interventions as well. They now also have another program called Peak, which is all virtual, but the idea is it's intensive. You're doing this 5 days a week, actually, as a difference to what we often see, where it might be, you come once a month for certain of the groups, or once a week. All right. And then another interesting newer model is this Prevail model. And so here they actually split things into tracks. They have an initial consult with an advanced practice provider, and then they either go into, some people know they just want the interventions or the medications, and so they go into the intervention track then for injections or medication management, or they have the active management of pain track, which I talked about, and then the interdisciplinary track, where this is their most unique aspect of this. They start everyone with pain school, which is run by pain psychology generally, and some others. And then they have an evaluation, actually, where they are having one person, I'll show this on the next slide, meet with all of this team. So psychology, physician, pharmacy, physical therapist, and dietitian, and also incorporating complementary and integrative approaches. And then they have monthly coaching calls. They use the whole health coaching, and then they again reevaluate. So this model has been shown to have some evidence, very preliminary research, I will say, but increasing satisfaction, 9.2 out of 10. That is very high for pain management, I will say. Sometimes some of the most difficult to manage conditions, and improvements in pain severity, pain interference, and physical functioning, as well as sleep. So it is effective. These multimodal modalities are effective. All right, and I'm just about to finish up here, but just to bring it all together. So the idea with the whole health approach is we're looking at everything together, right? This is not just, say, alternative or complementary approaches to replace our conventional care. We're using these things holistically. What is going to be best for the individual person in front of us, or on the population level as well. So conventional care, self-care, whole health and lifestyle medicine are manual therapies, movement-based, and psychological and mind-body approaches, among others. And so just to wrap up here now, looking ahead, how are ways that you can integrate whole health? So first, just having a discussion, right? Showing that circle of health diagram, perhaps, that's readily available on this website that's shown. There's a whole library, va.gov/whole health. They have some really great resources. Having a discussion about the map, and how you can map to the map. It's great for rapport building, and it can really help to get a sense of what is it that truly matters to the patient. Checking out the whole health library, the apps, identifying who are the people and your resources that you have access to, or who might be in your catchment area. And then perhaps signing up for a training, right, for this approach too, that's offered through mostly the VA right now, but there are many others. Actually, there's talks like this one and some workshops that are done at some of the different conferences as well. All right, so I am going to end there. Thank you for your time today. So glad to be with you, and I will open it up to questions.
Well, thank you so much, Dr. Spertus. That was really a wonderful presentation. It's packed with a lot of information. So if anybody has any questions, you can either raise your hand or you can type it into the chat messages. So it looks like you've given such a thorough presentation that there aren't any questions as of yet. Oh, um, terrific presentation.
Thanks, Karen.
Okay, so I have a question. So when you're measuring pain changes, um, is it through like a visual, like how would a physician be able to interpret whether their interventions are working?
Great question. And so there are different ways to do this. So there's the difference between the research, of course, and then what are we doing clinically. Um, at the at the research level, there's lots of different ways that this is being tracked, and actually, still the gold standard is the visual analog scales that you're referring to. There's other ones too, just numerical pain scale ratings, which is like our 0 to 10 that we always talk about. And actually, that has been shown to be helpful, but there are other things that we might look at as well. And so within the VA, say even for we do a type of acupuncture called battlefield acupuncture, and it's integrated into our notes to gauge other things. So not just the number of the pain itself, but how is pain interfering with certain things. It's called, I can't remember actually the name of this scale, but it is part of the military and veterans approach. We look at pain interference with usual activities, with mood, with sleep, with stress in addition. And so those are tracked actually every visit. We have pain pharmacists actually who are looking at some of the other measures as well, and to see what our levels are for that. Within different clinics, there are different ways that we might measure it. Some of those virtual reality devices that I talked about, they will actually do some of their own measurements, and I actually get those reports back when those get sent out. So they actually use scales called PROMIS scores, which looks at pain and pain interference as well.
Oh, okay, that's really very helpful. So do you use, this is my question, NADA, is that, or what is the military one, isn't it? Is it just so that I could look up? Um,
Let me um, let me tell you actually, because I have that in another presentation. Um,
I know
it's
it's
called
usually in the ear, right?
Yeah, okay, I see it. It's the DoD and VA Pain Supplemental Questions, or DVPRS, Defense and Veterans Pain Rating Scale.
I see. Okay, but the battlefield is acupuncture is in the ear.
That's done in the ear, that's correct. Yeah.
Oh, okay. So there are some questions here. Okay, so one is from a pediatric physiotherapist who has chronic pain patients, and they say it's difficult to practice mindfulness in kids. Could you please suggest some substitutes or some ways to integrate mindfulness, which can be advised to parents?
Yes, that is a great question. And kids are different, and especially depending on the age, right? They might not be able to sit there for a formal meditation. And so there are other ways to be creative about how to do this mindfulness thing. There are actually some interesting books on this topic as well. And so, like storybooks that you can actually use that helps with mindfulness. Reading in general is actually a mindfulness technique, right? Because we're focusing on something that's in our present moment experience. Um, Imagery, imagination. Kids often do not have to close their eyes to have this imaginative approach. And actually, we do this in hypnosis often as well. We often don't need them to close their eyes, but have them imagine something fun that they're doing. I believe there's some new modules on one of the apps that goes into some of this as well on the Waking Up app and possibly the Calm app as well.
Great.
And it can be shorter interventions can be helpful for kids too, at least for initial. So not necessarily sitting in, a lotus position to meditate for kids.
That makes a lot of sense. So here's another question about pelvic floor physiology integrated into whole health approach of chronic pain. Do you have anything to talk about with that, especially in patients with complex pain histories?
Yeah, absolutely. And this is something that comes up and, in chronic pain. And we try, so it's interesting that you say that because like in our clinic, it's often, low back pain all the time or sometimes neck pain. But it's really important to ask about all the different types of chronic pain that are going on, because just like the mind and body are not separated, that's an artificial construct. The rest of the body is not separated out from the spine either, right? So it's one body, one person. And so really that is very much in line with the whole health approach, integrating any therapies that might be useful. And so if there's pelvic pain, our pelvic PT specialists are really great. That's what they do, and integrating that in. There's actually a lack of awareness, I think, about that particular type of PT. At the VA, we do have a dedicated referral for that.
Oh, that's great to know.
And I would say sorry to add to that, because it is complex. There can be trauma associated with that as well. So really adopting a non-stigmatizing, patient-centered approach is very important for that. Really being mindful about that. A lot of times with pelvic pain, there is a trauma history there too, and pretty much all the PTs who practice that are trauma informed.
Wow, that's really very important information. So here's another question. So this person has been working for a while on paralyzed stroke patients, and they have a question to minimize heat exposure to manage and neurotransmitters. So have you heard about that to manage lower back with sensory pain in stroke patients?
I'm not sure I completely understand the question. Um,
Yeah, it was kind of I'm probably not reading it very
I
clearly.
see I see it in the chat. If if you wouldn't mind, if you're still on, unmuting yourself and bringing that forward, I'd be happy to answer it though.
So I don't see.
All right, if they're not, what I would say, just looking at stroke overall, I'm not familiar with, the this effect of heat and neurotransmitters necessarily. Um, what I can say is that for stroke, there are a lot of different interventions and modalities that are used. Um, I was just having a conversation with someone recently, one of the local acupuncturists, and actually in China, it's like a first line therapy for stroke to use even acutely, traditional Chinese medicine and acupuncture, with lots of good research, mostly out of China. But for some reason in the US, we are not using that as much, because we mostly are thinking about um, pain with acupuncture, right? And so it actually just has to do with awareness, but it can still be a very valuable tool, as can many of the other things. There's for thalamic strokes, that actually results in non-physical, so to speak, because it has to do with the way it's processed in the brain, but pain that exists. There can be this, you can use similar approaches that we use for, say, phantom limb therapy. So mirror therapy is actually an interesting approach that can be used for that, or some of these other mind-body techniques too. With the role of heat versus cold, I don't know enough about that, I will say, but I'm interested to know how that can be used too.
Well, thank you for that, talking about stroke patients and some of the acupuncture that's been used. So are there any other questions? You've gotten a lot of positive feedback.
If there aren't any, Michael, I want to thank you very much for your presentation. It was excellent, and we hope you'll come back and give another one in the future.
So this
Great.
is Dr. Bob Schwartz. He's the director of the Osher Center for Integrative Health here at University of Miami. Just so everybody knows. Oh, there is one thing. I think they're talking about heat pads and TENS. So the person.
Yes. Okay. So I'm not familiar specifically for stroke, but yes, those are used. The evidence is plus minus mixed, I would say in general for low back pain, and I would imagine including if it's related to stroke. Um, the They can be used, and again, this is going to be more individualized. When we look at the data overall, it can be helpful just temporarily, is usually what we find, but it's going to depend on the person.
Okay, yeah, that makes sense. You had that in your list of things that don't seem to work in chronic conditions. Okay, I think that's everything that, unless you have anything else you want to add today.
I do see just one more question. I know we're over time, and that question about complex regional pain syndrome. That is quite the Pandora's box, I would say, and would require a lot. But I would say the same theories still apply, the same principles here. How do we go about this in a whole health approach? How are we dealing with the person in front of us? What is it that truly matters to them? We certainly see many patients with that within our pain clinic, and they get referred to me. And then, there are many different approaches that we can use.
All right. Well, that was really informative, your talk. I've learned quite a bit. Thank you. We really appreciate you taking your time to talk to everybody about this really important topic.
Well, thank you all. Glad to be with you today.
Okay, so thank